So hello everyone, welcome back to the part 2 of Anemia Mukt Bharat. I hope you have already gone through the part 1. If not, you can find that link in the description box of this video. We will have a brief recap here. So in part 1, we had seen about the overview and introduction. We had seen about the 6 by 6 by 6 strategy. By 6 by 6 by 6, we mean uh, 6 target beneficiaries, 6 interventions, and 6 institutional mechanisms. So this is something which is very important for us. We had seen about the HP testing as well, the machine that can be used, and the digital and the manual machines that are used. We had seen about the iron folic acid prophylaxis, the dose for the various beneficiaries, and we had talked about the deworming schedule using albendazole 400 milligram medicine. Now here, firstly, we are looking at management of anemia. We are moving forward in the AMB strategy, that is the Anemia Mukt Bharat strategy. We are moving on to the management section, and as a part of management, firstly, we are looking at screening. So we talked about the target beneficiaries, but you need to screen them for anemia or for the HB levels. Obviously, we are talking about low HB levels. Where would you screen them? So as far as the 6 to 59 months are concerned, which commonly are known as the preschool children, they may be available in Anganwadi centers. So you can screen them there. Few of them may be available in schools, like very early part of the primary schools, or there may be play schools and kindergartens in some areas. And these children can be screened during the village health and nutrition day, and the frequency of screening for this age group is periodic, which is to be decided by the peripheral nodal officers, that is the taluka officers, the district officers, and even the medical officers of the local PHC. Obviously, what would, now this is not mentioned categorically or particularly, but what would determine or define the frequency? When we say periodic, how periodic? It can be 3 monthly, it can be monthly, it can be 6 monthly, it can be yearly. But how, what should be the frequency? How to determine? So obviously the available resources, how scattered is your population, how much population of this age group you get at one place, and how, what is the prevalence of anemia as per the available data. These are some factors which would definitely influence the frequency of screening in that age group. Moving on to the 5 to 9 years, the primary school children. So Rashtriya Bal Swasthya Karyakram and other forms of school health checkups present us the opportunity to screen this age group, and this screening has to be done annually. Similarly, adolescents are also to be screened under the RBSK and other forms of school-based health checkup programs or strategies or interventions, and the screening frequency is annually. Very important to note and to mention and to understand in both these age groups is that there would be some part of uh, this age group, both 5 to 9 years as well as adolescents, who would be out of school. Not necessarily everyone would be enrolled in school. It's unfortunate it's that way, but it's a practical, real, hard fact of our society in both in urban as well as rural areas. So your RBSK or your other forms of health checkup strategy should be able to catch hold of these out of school candidates from this particular age group, and the program should be able to screen these 5 to 9 year olds and these adolescents, girls and boys as well. Moving on to the pregnant women, or better I should say pregnant and lactating women, so obviously these can be screened at the medical checkup on a monthly basis in the Pradhan Mantri Surakshit Matritva Abhiyan health checkup, and every contact there has to be a screening for anemia. At every point of contact, there has to be recording of hemoglobin reading for the pregnant woman. Moving on to treatment of anemia. So when you read the AMB, that is the Anemia Mukt Bharat document, or even when you are trying to reproduce it, yeah, in form of an answer, obviously this is the best way to do it in form of flow chart. But for purpose of understanding right now, we will divide it into 3 subsections, and we will come back to this chart in few slides. So I have divided into 3. The first subcategory is pregnancy with mild or moderate anemia, where hemoglobin is less than, beg your pardon, where hemoglobin is greater than 7 gram percent. And the first category is all what is mentioned above. Along with that, gestational age, this GA stands for gestational age. It is more than 34 weeks, and the lady is compliant to oral iron. So in such a case, the treatment would include 2 iron folic acid tablets with strength of 60 milligram of elemental iron and 500 microgram of folic acid, and it has to be taken daily. Now, this is not the end of the statement. Very important is that there needs to be a follow-up after 1 month. After 1 month, we have to again check the hemoglobin. If there is improvement in hemoglobin, and by improvement we mean more than 1 gram percent improvement, then we continue this dosing for further improvement. But if the improvement is less than 1 gram percent, then we refer to a higher center, which may be a first referral unit or a community health center. So don't end your story over here. Remember this as well, that there has to be a follow-up, and accordingly, on the basis of the increase in hemoglobin, the further course of action is decided. The second category, so the HB level is same. It is mild to moderate anemia with greater than 7 gram percent of hemoglobin. But if the gestational age is more than 34 weeks, that is, there is not much time left in going into a labor or a cesarean section, or if the GA is less than 34 weeks, but the lady is non-compliant to oral iron, she is having nausea, she is having vomiting, she is having that, that metallic taste, or she may be having constipation, or she may not be liking the black tarry stools due to iron, or due to one or more of these reasons, if she is not able to consume the oral iron on a regular basis, then the solution is parental iron. Parental iron has to be given for 1 month. The available formulations are iron sucrose and ferric carboxymaltose. So one of these preparation can be selected. And again, improvement to greater than 10.9 gram percent hemoglobin is what we are looking for. Just to as a recap, 11 gram is the cutoff for normal hemoglobin in a pregnant female. So we are looking for normal levels. So if this normal level is achieved, then no further treatment is needed. In fact, no further prophylaxis is also needed. But even after parental iron, if inadequate improvement is there, then this warrants a referral to a first referral unit or a community health center, or for that matter, even a district or a sub-district hospital. That is a higher center, which will have more equipped facilities. The third category is pregnancy with severe anemia. That is, the original recorded hemoglobin is less than 7 gram percent. Now, the program says that you have to divide this into less than 5 and more than 5. If it is less than 5, then there is not much of an option other than that we go for a whole blood transfusion. Now, if hemoglobin is 5 to 6.9, but gestational age is less than 34, that is, again, there is time available for waiting for a natural increase based on our supplemented iron, then we go for a parental iron therapy. But if gestational age is more than 34, there is not much time left for the delivery to happen. It may be in form of a normal labor or a cesarean section, that is immaterial. But by 34 weeks, we mean that the pregnancy is almost nearing its end. Then again, the best available option is that you go for a whole blood transfusion, looking for an increase in anemia. Now, when we say whole blood transfusion, 1 pint of whole blood is expected to raise hemoglobin by 0.7 to 1 gram percent. Now, how much would this sustain will depend on the body's characteristics. Is there a breakdown of red blood cells? Are the iron stores too low? Is the diet too poor? So how much it would sustain is a different matter altogether. But as far as blood transfusion is concerned, we are looking for per pint increase of around about 0.7, you may say 0.5 to 1 gram percent of hemoglobin. Okay. Now, some details about parental iron therapy. So, oral iron, the problem with oral iron is that there is poor compliance amongst all beneficiaries, and that is because these side effects are very common with oral iron. There may be nausea, there may be vomiting, there may be indigestion, there may be constipation. With that, the beneficiary may have black colored stools, The beneficiary may be having, loss of appetite, or even if the appetite is good, the beneficiary may be complaining of certain kind of a metallic taste or a very different taste from what she or he is normally used to. So these are all the factors which may lead to a poorer compliance of oral iron. That is the beneficiary not taking your iron folic acid treatment or iron folic acid prophylaxis for that matter. So not as an option for prophylaxis, but definitely for an action as an option for treatment of anemia, we have the parental iron. The commonly used preparation is iron sucrose, where the dose is 200 milligram per dose, it is 200 milligram per intervention, and it has to be diluted in 100 ml of 0.9% saline. That is normal saline, 100 ml of 0.9% saline. And this dose can be repeated, but it should not exceed 600 milligram per day. If you have to give more than 600 milligram per day, based on the iron requirement, which we would see in the next slide, then you need to repeat it. And actually, the literature says at many places that if you have to repeat it, preferably repeat it with a 1 day gap. That is, you don't give the next dose on the next day, but preferably call after 2 days or 3 days. Now, during this iron transfusion, vitals need to be measured at regular intervals and especially after infusion. So this is something which is very important when a parental iron therapy is given. Now, how is the iron dose calculated? So iron dose is calculated by body weight into 11 minus actual HB into 2.4 plus 500. Now this formula, every term has one or other, characteristic about it. Firstly, which body weight? Today's body weight, yesterday's body weight, 24-week body weight, pre-pregnancy body weight, which body weight? So ideally, we want a pre-pregnancy body weight. Please remember this carefully. We want pre-pregnancy body weight. Obviously, many females will not have the pre-pregnancy body weight. So the body weight we consider is the body weight at first ANC checkup, that is at the time of registration, can be considered for calculating the iron dose. 11 is what we are taking because we want a minimal of 11 gram percent value. Actual HB is the latest measured hemoglobin based on one or more of the available methods. 2.4 is the multiplier. This 500 milligram is for increasing the iron stores. Body doesn't use all its iron at one go. Body has mechanisms of storing iron in multiple forms. So this 500 milligram is basically to increase the iron stores of the body. What are the contraindications to this parental iron? So hypersensitivity or known iron overload are obvious contraindications. Systemic conditions of heart like acute heart failure or liver cirrhosis or renal failure warrant us from, deciding against a parental iron therapy. Thalassemia, sickle cell anemia, and other hemolytic anemias, where basically there is breakdown, warrant against use of parental therapy. And anemias which are not due to iron deficiency also obviously are conditions where iron should not be used, parental iron should not be used. Obviously, if it is a B12 deficiency anemia, then you would go for B12 treatment. And maybe if the gestational age is high, or if the clinical picture is such that not many options are available, the options of blood transfusion is always there. I would like to categorically mention over here that the literature clearly states that the difference in increase of hemoglobin based on oral iron and parental iron is not much. You are not listening anything wrong. So irrespective of the mode of iron you use, we would expect again the same as 1 pint of blood, 0.5 to 1 gram percent of rise per week. Now, we few slides ago, we saw that we want this much in a month, but ideally iron therapy should be able to increase this much of hemoglobin per week, irrespective of oral or iron. So don't take away the concept that parental iron increases hemoglobin better than oral iron. So what are the benefits of parental iron is that when a lady is non-compliant to oral iron due to the side effects of oral iron. And there are also issues about bioavailability of oral iron, which we would see in coming slides. So there definitely in parental iron, because you are parental, the word itself means you are surpassing the gut. You are bypassing the gut and you are trying to introduce the iron directly into the blood system, which would be available for liver, spleen, bone marrow, and all the hematopoietic system. So there the parental iron definitely beats oral iron, but it does not mean that iron sucrose or be it ferric carboxymaltose would be able to increase more amount of hemoglobin per week or per month or whatever frequency you take. In an ideal world, whatever your iron sucrose can do, the same amount of increment can come from any oral iron preparation, provided the bioavailability is taken care of and provided the lady or the beneficiary is compliant to that oral iron also. So don't take that wrong concept that parental iron is better in increasing hemoglobin. It has other benefits, but definitely not better in increasing hemoglobin per week or per month. So coming back as a recap, anemia in pregnancy, that is hemoglobin less than 11 gram. So we are dividing it into mild and moderate at one place and severe in the other wing. In mild and moderate, if gestational age is less than 34 and compliance to oral iron is there, then we give 2 tablets of iron folic acid. If there is no improvement after 1 month, then there is this warrants a referral to a higher center. If the improvement is there, then you continue with the 2 tablets. If gestational age is less than 34, but there is non-compliance to oral iron, and also if there is gestational age of more than 34 weeks, then there is not much time left to experiment with different available oral iron preparations. That is why we go to parental iron, which can be iron sucrose or ferric carboxymaltose. Again, if here there is no improvement or less improvement, by less we mean less than 1 gram in 1 month, then this warrants a referral to a higher center. But if adequate improvement is there and if it goes beyond 10.9, that it comes to the normal level of this 11 gram per deciliter, then it is mentioned that there is no need for even prophylactic iron folic acid tablet. Moving on to the second wing, that is the severe anemia. If hemoglobin is less than 5, then there is not much of an option. You go for a frank whole blood transfusion. If hemoglobin is 5 to 6.9 and gestational age is less than 34, so you can refer to a higher center for intravenous, that is parental iron preparation. But again, if gestational age is more than 34, we don't have much time left, then we go for immediate hospitalization and blood transfusion. Moving ahead, we go on to the SBCCs on anemia as part of the Anemia Mukt Bharat strategy. So what is this SBCC? So SBCC stands for Social and Behavior Change Communication. Now, as per this AMB strategy document, this SBCC is divided into these 7 steps: awareness, desire, knowledge and skill, trying out the intervention, which in this case is IFA prophylaxis or IFA treatment, repeat the intervention, maintain and sustain. Now, very important to know that this happens in a cyclical form. There would be awareness, there would be desire, there would be knowledge and skill, there would be trying out the intervention. Few of them may repeat it, maintain it and sustain it, and it goes on. But there would be dropouts at every point. Dropouts at every point. Dropout would be at every point. I'm just drawing 3 points over here. So first we go to awareness. So obviously by awareness, we mean being aware of there is some, so for example, pregnancy. So the beneficiary should be made aware of that there is something known as a iron folic acid prophylaxis, and it should be taken by all pregnant ladies. In prophylaxis, we are giving to all pregnant ladies for 180 days in second and third trimester. And then there has to be desire. I'll come back to this desire. And then there has to be knowledge and skill. So knowledge and skill would include what is the tablet, where is the tablet available, how does the tablet look, how many times the tablet has to be taken, which is the best time to take the tablet, uh, what could be the potential side effects of tablet, which side effects are okay, they can be they are normal side effects, which side effects are the dangerous side effects, or side effects which should warrant going back to the healthcare provider. all that would come in knowledge and skill. Trying would be trying the actual intervention, repeating it for the next day, the next week, the next month, and so on, maintaining it over a long duration and sustaining it. Now, based on my knowledge, my expertise, I would say that the most important of these 7 steps is desire. Your awareness and your health education, which leads to knowledge and skill, should be able to create a desire amongst the beneficiary. All programs and strategies which have been able to do that generally are expected to work more, or generally have worked more across the history of our national health programs and strategies, as compared to those which were not able to create desire. Now, what do we mean by desire? So, for example, forget anemia for a few seconds. For example, you are treating diabetes or you're screening for diabetes. The beneficiary or the patient should understand that this screening or diagnosis or treatment is not for you. It is not a healthcare provider's diabetes. It is that patient's diabetes. It is a patient's blood sugar. In TB program, it is the patient's TB program. In immunization program, the parents should understand that the immunization is for protecting their children. It is not a compulsion from the system's side. Similarly, here also, your beneficiaries, your pregnant ladies, lactating mothers, school children, in school children's case, obviously the parents, the adolescents and their parents should understand that it is for their betterment, their better HB levels, their better health, and their overall better growth and development. And in case of pregnancy and lactation, obviously their better children, fetus and children, is for what this iron and folic acid is being given. And that is why the most important part of any health program, any health strategy would be that you create a desire. Now, another example I would like to give over here, that people used to stand for hours. People used to sometimes go to vaccine centers in the night and spend night on the gates of vaccine center so that they get a turn to get their Covishield and Covaxin, shots. So that was a strategy, that was a vaccination program which was able to create desire. They believed that yes, getting this vaccination is important. Getting this vaccination will save us from COVID, and at least from severe forms of COVID. And that was the kind of desire which led to a grand success of the COVID vaccination program. So similarly, all your health programs, in this case, your Anemia Mukt Bharat strategy and the SBCC, which is done for this, should be able to create this desire. If this desire is not created, then the steps that are below, especially these maintain and sustain one, these repeat, maintain, and sustain. These are definitely something which would be very difficult. Now, you have to remember that the difference between, say, an immunization, be it as I gave example of COVID immunization, COVID vaccination, or our under five vaccination on one side, and say anemia prophylaxis or a TB treatment on other side, the difference is that that is a generally a 1 point contact. Even if the pediatric vaccination which we give, it is repeated, it is 7 or 8 times over a year. But here we are talking about 180 days of iron tablet in pregnancy, 180 days in lactation. We are talking about one per week over that, and over those many months and years, for our preschool children, for our school children, for our adolescents. So these steps of repeat, maintain, and sustain become much more important in strategies and interventions like one on anemia or like the TB treatment, as compared to those which are 1 point contact or a one step intervention. For example, your vaccination. So various forms of various pamphlets, charts, etc., slogans, etc., can be used for promoting good diet, good practices, and uh, you know, in a as a whole, inculcating good dietary practices with respect to iron. So this is one of such chart that is used, or that is depicted in the document. Now, just if we have to go through the shown food items, So here in iron-rich foods, we have the green leafy vegetables. We have the various forms of pulses which are rich in iron. We have the muscle part of it, that is fish, meat, chicken, and we have the yellow fruits. So the various iron-rich foods. Also shown over here are the vitamin C-rich foods. We will talk about this in the subsequent slide. And there, the right side of the poster talks about what should be avoided after meal. So there is tea, there is coffee, there is this soft drinks and high sugar containing fruits, foods. Beg your pardon. There is cigarette. There is alcohol, and there are the mint preparations. Why? How? We will talk about this. So important points to regarding iron, which should be part of iron-based health education as far as possible. Obviously, what can be given as part of health education and what may not be given or may be restricted depends on the what to what socioeconomic class, to what education class are you catering your health education to. But at least as students we should know, or we should remember these few important points regarding iron, which may be inculcated into anemia based health education as a whole, or few of these points can be taken in anemia based health education. Firstly, iron is found in most naturally occurring forms as Fe3 plus, that is ferric, whereas iron is absorbed as ferrous form. This ferric form, especially in our high cereal diet, is in conjunction with the alkalis. So it is ferric tannate or ferric acetate, so on and so forth. We want the iron to be Fe2 plus. Our receptor is also divalent metal cotransporter, DMCT. So we want the iron to be in Fe2 plus form. One of the major ways, or one of the chief ways how this could be achieved, is that you add acid to your diet, and one of the commonly available acid which is harmless and which should be actually consumed in diet is vitamin C. So that is why even in the last slide you saw that iron rich foods should be combined with vitamin C rich foods, and as far as possible alkalizing agents like cereals, like sugary foods, like soft drinks, or even tea and coffee which lead to tannates of iron should be avoided. So these are all what should be avoided. Then there is a concept of heme iron and non-heme iron. Heme iron is the organic form of iron which is available in muscles. So obviously only non-vegetarians have that option. The vegetarians and the vegans don't have this option. Non-heme iron, when we say, we are talking about the inorganic iron, that is the Fe3 plus and Fe2 plus, which I talked about. But another important fact of our society is that even the non-vegetarians are infrequent consumers of muscle. Some may be due to the socio-cultural practices, some may be due to the religious beliefs, some may be due to the simple fact that the non-veg diet is that much costly to be consumed on regular basis. So we would obviously talk about this in detail about all these characteristics of iron and its absorption and its bioavailability when we talk about iron chiefly in the nutrition videos. But here these are some salient features which a student should remember whenever we are talking about health education related to anemia and iron deficiency anemia in particular. Then moving back to the AMB anemia Mukt Bharat strategy. So there is something known as the supply chain management, which would constitute planning and forecasting how much would be required over next month, next quarter, next year. Indent, placing the indent and procuring that those particular number of iron and folic acid tablets, your warehouse and inventory management, and the distribution as per the beneficiaries and the various other mechanisms. Now, in inventory management, which is the inventory strategy that should be used? So you would have heard about FIFO, that is first in, first out, or LIFO, that is last in, first out. But logically speaking, here the best inventory management would be EEFO, that is early expiry first out. So whenever a subsequent batch of iron comes, it has to be, the expiry date have to be gauged against whatever is the available stock, and whatever is dispensed firstly should be based on early expiry. Whatever expires early would be distributed early, and so on and so forth. Now, how do we indent? So there would be formula for each beneficiary group. Here we are taking example for pregnant women. So in pregnant women, the consideration is that half would require one tablet and other half would require two tablets. Now this is what the strategy document mentions, but here I would like to remind you, one tablet, when we say, we are talking about the IFA profile axis. We are talking about the IFA profile axis. One tablet, red goli, 180 days in second and third trimester. And when we talk about two tablets, we are basically talking about the IFA treatment, the oral iron and folic acid treatment. So around about 50% of anemia is there. Actually, it is much more than 50%, but for this calculation, we have taken 50% anemia amongst pregnant women. So 50% of your pregnant women would require the prophylaxis and 50% would require treatment. So accordingly, the formula becomes 180 into pregnant women by 2. Pregnant PW means the number of pregnant women in your area. 180 days, so 180 into number of pregnant women by 2. That is one tablet, the group which would require one tablet. 360 into PW by 2. That is the group which will require IFA treatment, oral IFA treatment. So two tablets. So that is why here we are taking 360 and not 180. Plus 180 into live births, because you have to provide 180 days of IFA prophylaxis for all lactating mothers, and add to this 10% of buffer stock. So whatever comes from here, 180 into PW by 2, 36 plus 360 into PW by 2 plus 180 into number of live births, you add another 10% to that as a buffer stock. And then, but obviously the actual indent would be whatever is estimated from this particular formula on the previous line, minus whatever is there in hand and whatever is in pipeline based on previous indents placed. So this is obviously, common sense. This is based on the assumption that half would require prophylaxis and half would require treatment. And accordingly, we have the formula taking into account half would require 180 tablets and half would require 360 tablets for the same 180 days of second and third trimester, because they would be anemic. Now, similarly, there have to be indent calculation for red tablet. Reminder, red tablet for pregnant and lactating females. For blue tablet, that is tablets which are there for adolescent boys and girls. For pink tablet, that is iron prophylaxis, iron and folic acid prophylaxis for 5 to 9-year-old children. And also indent calculation has to be there for IFA syrup, which is for 6 months to 6 years of age group. And not to forget, there will have to be indent calculation for albendazole also, because deworming is also one of the key strategy of our Anemia Mukt Bharat. Finally, there is an Anemia Mukt dashboard as per this strategy document. Here we are able to visualize all the 6 by 6 by 6, that is the 6 target beneficiaries, the 6 institutional interventions, and the 6 intervention that we are going to make as per the AMB strategy. Data is populated based on the HMIS reporting by the various centers. The denominator for calculating the coverage, the denominator is based on census 2011, and then further additions and multiplications are done based on whatever is the population growth estimated. But this denominator would be fixed for a particular financial year. Apart from all this, there are key performance indicators. So the last slide, what we saw, red tablet, blue tablet, pink tablet, IFA syrup, and deworming. So in brief, you can say these 5 would be amongst the key performance indicators. Your coverage of red, coverage of blue, coverage of pink, coverage of IFA syrup, coverage of deworming. So that is where our iron program has evolved. 50 years ago we would only be talking about how much iron we are giving to our pregnant and lactating females, but now it is not so. We are going for a holistic approach, we are going for a life cycle approach. We are giving iron to pregnant and lactating, definitely, but we are also giving blue goli to adolescents, we are giving pink tablets to our primary school children, we are giving IFA syrups to our preschool children, and with all this, depending on the age, we are also giving deworming to prevent iron losses to the intestinal worms. With all this, the dashboard also gives Q1 to Q4, that is quarterly progress report. And obviously, ideally for all districts metropolitan areas, states, and the whole country, we would want that all Q1 to Q4, the trend is uprising. So in summary, in Anemia Mukta Bharat, we looked after the 6 by 6 by 6. We looked after the IFA prophylaxis and deworming, how much, when, where. We looked after HB testing. We looked after IFA based treatment, oral, parental, and blood transfusion based on the HB levels, the gestational age, and also based on the compliance to oral iron. We looked after the supply chain, and one of the important part of that module was indent calculation. And finally, we had a word on Anemia Mukta Bharat dashboard, which takes care of the monitoring and evaluation part of this Anemia Mukta Bharat strategy. If you like this video, do like and do comment on what could be better, or if you want to ask a question, do subscribe to this channel named Low Hanging Fruits of Community Medicine, and definitely do share it with your peers so that they are also able to gain some additional knowledge on this Anemia Mukta Bharat. Thank you and bye bye.